Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome back to another episode. Today I'm with Dr. Vic Martel. He is a general dentist practicing in Florida. Vic, thank you so much for joining us on the podcast.
Thank you for having me back again. I really appreciate this, and I hope it's it's pleasurable to everybody and informative. And I think it's something that the surgeons will enjoy because it's something that really kind of hits to the heart of their practices. So whenever you're ready, we can go.
Sounds good. So we wanted to kind of discuss comprehensive treatment planning and how that involves the kind of the generalist and the specialist. But how would you define comprehensive treatment planning?
Well, first, let me just say that I've been teaming up with surgeons and their general dentists for probably 20 years now, trying to put them together so that they can work interdisciplinary wise. And that interdiscipline is what creates or helps create comprehensive treatment planning. And I think if surgeons would take the time or the energy or the resources to help them understand it, I think everybody's practices will grow, kind of like what we talked about last year sometime. But to give you an idea of my view of what comprehensive treatment planning is it's this detailed roadmap of the overall health, not just the patient's immediate needs, like, my tooth hurts, my tooth broke, and things like that. And that's where dentistry has kind of gone astray. And the reason is, and we can probably talk about this later, but the reason is that we're not taught it. And I'm, even though you're an oral surgeon, you went through 4 years of dental school like we all did. And one of the cruxes of my programs, my CERT programs, is the average general dentist is either not taught or still doesn't understand how to comprehensively treatment plan patients. In other words, what I call big picture dentistry, looking at everything, cause and effect, and what happens here, why did this happen? And when they do that, which is really a strong point of mine over the years and learning from the greats of Dawson and Spear and everybody, is you'll find that the number of patients you need within your practice, new patients, goes way down. Because what you're really doing is treating somebody holistically, and we'll talk about that in a little bit, so that we're looking at everything and not just putting immediate needs and then, getting the patient out the door quickly. And, you may have had that crown there, but what did you miss? What didn't you see? And I think by putting the surgeons and the generalists together in a room, which is what we'll talk about, and helping them understand this, I think everybody but benefits. And most importantly, and if you've ever heard me, well, any of the people that have always heard me speak live, is the bottom line of my programs is I really care about the best for the patient. It's never only about the money. And granted, we all have to make a living. But ultimately, if you can treat somebody holistically and get an overall long-term plan for them, wow, I think your practice will change and the patient's lives will change. And that's the whole crux of what we do.
Yeah, I really like where you're going with that. I mean, I'm guessing all too often a patient will come into the general dental office, say a tooth hurts, or, this one's been bothering me. They take a look. Okay, maybe that one's whatever, pulpitis, or needs a root canal. Okay, let's root canal and crown it, or it's cracked, you got to extract it. It's probably very focused to the patient's immediate need and not taking the overall picture of everything.
Yeah, and that's understandable, and I'm fully in favor of, especially when a patient's walking in pain. I'm fully in favor of handling that issue. But what I think a lot of generalists fail to do, and I mean literally at the first visit, is a point of communication where they say, give an example, Grant, you're probably looking in your mouth, we're going to take care of this today, and you put them at ease, but you realize you have more problems than that. What I'm trying to do is get them that comprehensive exam so that we can go further with that. I'm going to meet their need for today, like a broken tooth or things like that. But ultimately, I need to get them to the point where I'm going to look at everything. We're going to look at cause and effect. We're going to look at the whole mouth. And what that becomes is, do they need their wisdom teeth out? Well, let's send them to the oral surgeon. Do they need implants? Do they need this and that? But ultimately, if you don't do that, you become this, and I don't mean this in a bad way, but it's going to sound horrible. You become this tooth fixer. Dr. Dawson used to call us physicians of the mouth because we're the only ones that treat it, right? An ENT looks straight past your teeth and looks down your throat, whatever that happens to be. But we're the only ones that understand the whole concept of comprehensive planning for the human mouth. And we need to take that more seriously. And when we do, our practices grow at a level where we're not out looking for the next profitable procedure in your office that you may or may not be qualified for. You're going to be trying to help this patient maybe go to the surgeon, go to the periodontist, get some implants, help them interdisciplinary so that everybody is on board, and ultimately we come up with the best long-term plan for them. And that requires patience, and we'll talk about that in a little bit.
Okay. And you've mentioned the whole concept of comprehensive planning can grow your practice. It can increase patient trust. Any other benefits there to really focusing on this?
I start thinking, I go nuts about this stuff. I have 10 of them. Number one, it definitely improves the outcome, right? Because, you've seen this, I'm sure, Grant, in your practice, is that, you put an implant here or there for one of your referrals, but they didn't look over here, they didn't look there. And because of this quick fix mentality, other problems pop up. There's nothing worse than you're working on the left and now the patient has something going on the right. There's nothing, and that happens all the time. A perfect example for a surgeon and a relationship with a general dentist is you're putting an implant in number, a lower left molar, but nobody looked to see that the upper left molar is super erupted. What are you going to do about it before you put the implant in? In other words, even that small example is this, did you look, let's plan this so that it works out long-term, as opposed to let's just stick an implant in and fill a hole. And ultimately, now we have to deal with something else. Like, do we have to orthodontically move the upper tooth? Do we have to do a root canal, crown lengthening, and all this kind of stuff? Because we just didn't take the time to slow down and look at it from a big picture. So, from a patient standpoint, even though some of the dentists that have never tried this may not understand it, patients appreciate if you give them a clear plan of everything. And we got to stop being in a hurry to go, let me get that crown done. Let me get that instant production done. And let's sit them down and look at them and give them, I call it, when I do comprehensive presentations, I call it, let's give you a tour of your mouth. Let's look at everything. And ultimately, we're going to, if we have to phase this, we phase it. If we don't, we don't. But you're going to know everything when you leave, as opposed to just this little area of your mouth. And that leads to number 3, which is it gives them this big holistic picture, meaning here's everything you need. And whether that's ortho or whatever that happens to me, so that we can get your mouth healthy long-term. I think those things, which would be number 4, boost case acceptance, because patients look at you and go, wow, this guy really knows what he's talking about. It's this situation where it just makes it more complete, which literally helps. And you've seen this many times. It even helps in sequencing the work, meaning if I know everything that's going to go happen in the mouth, and maybe that lower left molar isn't the first thing I need to do, even though there's an implant going there. Maybe I need to do X, Y, and Z first in order to set that up. For example, what I just said, maybe I need to move that upper tooth that intruded so that I can do an implant in number on a lower left molar. So it actually optimizes sequencing, which ultimately creates a better plan. And then to me, and this is the very one that's really hard for some dentists to understand, is you're gonna get more. Your production is gonna go up. It's just simply, if you're just looking at immediate work, you're gonna get some production. If you look at big picture, and even if that's a 3 to 5 year plan for somebody, you may have gone from $5,000 worth of work to $25,000 worth of work because you're treating a patient holistically, and ultimately the production goes up. It may not be immediate, but it helps. Number 7 is it minimizes mistakes. If I have an orthodontist and an endodontist and an oral surgeon looking at my case with me, how many fewer mistakes are we going to make when we put all our heads together? That's the key, right? What it leads to is this collaboration with the specialist, so that And you know this, I've mentioned this to you before, I do a lot of trying to defend dentists and legal work to eliminate those kinds of problems, because the shared liability of experts are really building this case for this patient. Obviously, it gives them a better health, which is great. And then lastly, which is the one that's the hardest, because I think it takes time for the general dentist to learn this, is it just makes you a better dentist. It improves your skill sets. If you understand treatment planning, comprehensive treatment planning, you're just going to be a better clinician. It's just a completely different type of practice, because you're not this tooth carpenter. You're a physician of the mouth, which is really, really different for patients. So yeah, I try, and when I sit in my practice, and we'll talk about this in a few minutes, when I sit in the courses, this is something that they hear sometimes, and maybe you can tell me about it because you have referrals. They hear it, but are they going to do it? Everybody can agree with me or not agree with me. But if you do agree with me, are you going to commit to that in your practice, so that every patient that goes through your door that wants to stay a patient for a long term, are they planned that way so that we can achieve long-term overall health? And that's a whole different type of practice. I use this analogy sometimes, is like, if you're going to get your house inspected before you buy it, let's say you're getting a house inspected, you don't, and one inspector goes in and, opens the fuse box, shuts the door, kicks the pipes a little bit and says, you're good. But another inspector goes through the house. It might take 2 days, and he tells you about the roof, the plumbing, the electric, any crack in the foundation. They both call house inspections, but one is significantly different than the other. Well, we're the inspectors of the mouth. We're the people looking in, and these patients that don't, very naive or uninformed, don't know what's going on in their mouth, because not only do they not know, they can't see it. And when we rush patients through, not only are we hurting them, we're hurting the dentistry, because we're not helping them achieve their health. So that's my feeling about it as far as that's concerned. And then how we go there is a whole different animal. So
Yeah, I mean, you mentioned that maybe we aren't taught how to do this in dental school, or so that could be a barrier to doing it. What other barriers hold us back from doing comprehensive planning?
I think the number one barrier by far is time. And what do I mean by that? I think a lot of dentists, and that's just the way they run their practices. They want to see a patient, every 30 minutes and things like that. If I told them that I may spend an hour to an hour and 15 minutes on a new patient exam, they would be, you're crazy. You're losing money. And in one sense, they're probably right. For that one visit, I'm not getting paid this exorbitant amount of money, because my exam can only be so expensive, right? And my time is more valuable than that. But in essence, what I'm doing is I'm building up this relationship, and I'm looking at everything, so that what one dentist might see as this quick little visit, I may have a conversation, and over time, I might turn that into a full mouth rehabilitation. So time constraints is constraints. And secondly, not only with time constraints, let me give an example. And I'm sure you see these on Facebook and things, Grant, is I can send you 100 new patients a month, these marketing companies, and in my mind, I'm going, if you gave me 100 new patients a month, I wouldn't know what to do. I would probably go home. The reason is that the way I do an exam, I would never have the time to do that. Okay. It's because, and as a single practitioner, for most of my career, I was in a group for a while. If you gave me more than 20 to 25 new patients in a month, it would be too much, because with my exams that I do and my presentations that I do and seeing patients, I can't handle any more than that. But I may get 5 times the production out of that one patient than somebody else does, because not because they don't know how, but just because they haven't spent the time and the energy and everything else to get that one patient up to par and things like that. I think, and then secondly, I think we're just not taught it. In dental school, I don't know, Grant, where did you go to school, Grant? Dental school?
At UCLA.
Okay. Did you have and the only reason I'm asking is there's some that are changing. Did your dental school have a heavy emphasis on showing you how to do a comprehensive exam? And I mean, at a level where you're looking at the joints, the TMJ, the bite, the wear, the perio, the end. At that level?
I mean, I remember having a course, like to say, okay, here's how we do it. And there was an emphasis on the whole picture. And all that stuff. I mean, I think certainly not like the overall health, more just let's look at every tooth and the bite and, all that stuff. But
Yeah.
there was some minor emphasis.
Well, like I mentioned in my courses a lot of times is that if you remember, and I'm sure you do because you're fairly young, it hasn't been that long since you've been out of dental school, but think about how dental school is structured. Let me ask you a quick question, and you don't have to give me an exact answer, but I ask this all the time in my courses. I go to the youngest dentist in the room usually because he usually has the best memory because it hasn't been that many years since he's been out, right? And I say, how many crowns did you need to have to graduate? And he'll know right off the bat, oh, I needed 6 crowns to graduate. Well, how many root canals did you need? Oh, I needed 4 root canals. I needed this. I needed so many extractions. And my point is saying that was we're taught to do like these tasks, right? Requirements. You're taught a requirement. Nobody's telling you to put the big picture together, right? So all of a sudden you get a diploma and you got through school by doing these requirements, but now you're supposed to know how to comprehensively plan everybody. But in essence, you were never taught it. So this becomes something that is so I'm very passionate about by working with surgeons, and we'll talk about how we get there in a second, working with surgeons and general dentists. So let's slow down and let's look at cases one by one, and let's look at them from a comprehensive standpoint. And now let's put a treatment plan together for these patients that maybe you've never done it this way before. And guess what? The beauty of that is it helps the referral network, but it actually changes, if they want to stick to it, it changes the general dentist practices because now they're treating people holistically. I hate using that word holistically nowadays because now it's like in dentistry, holistically is, don't get root canals, get these ceramic implants. And I don't believe that that's holistic dentistry. I believe holistic dentistry is treating people, the mouth as a part of the human body, and let's look at everything and cause and effect. That to me is holistic dentistry. But that's the term it's being used for now. So, that's the third thing is they tend to help people's immediate needs. I get it, and you should, but only when it encompasses the whole plan. And then, you know this, Grant, because you haven't been out that long. Dentists have financial needs, right? They're coming out of school, they have big debt, they're trying to do production for the day. And that's hard to turn down a crown. I'll give you a perfect example I use in one of my courses. Patient walks in with a broken tooth. No pain, just some sharp edges. They need a crown. And ultimately, I may look at the patient and say to them, hey, let's take an x-ray. Yes, this tooth needs some work. But let me do this right now. It looks like I'm seeing you wear, your teeth are worn out. You've had a few other broken teeth. Why don't you let me smooth this down and let's set up an appointment for a full exam so that we can look at everything and then we'll give you the plan. Is that okay? It's that simple sometimes, as opposed to, let me hurry up and grab my syringe out, get them numb, prep a tooth, and now you may never see the patient again because you've built no relationship. But you got that production for the day, right? It's one of those things that really is something that, it may seem like an immediate gratification, but in the long run, I think it hurts you. And then lastly, what's another barrier is a lot of patients don't understand this. If you tell them, well, you enter our practice through a full exam, they're going to go, I just want a cleaning. Because even in as new patients, and I'm going to get a lot of slack for this, but I say it all the time. I don't think any new patient in a general dentist practice should be brought in for a cleaning first. I think it's a very big mistake. I think you don't know their perio condition. I think you can't build a relationship, and you certainly can't give them a plan and do an exam that you're going to treat them, their whole mouth in the long run. I think that is something that dentists tend to do because they just want to make a patient happy. I get it. It doesn't make it the best way to do it. It's just the way that they've been taught. And ultimately, I think they're missing out on a lot of dentistry. And I think the patients are missing out on getting a full, long-term health plan, which is what I call, what we're talking about. So that's the only barriers I would say that are really super important.
Okay. Now, as the specialist, because if we're gonna, sometimes I talk to our patients. Like I'll have a patient sit down in my chair and they'll say, "Should this tooth come out? I'm just not sure." Yeah, and of course I'll explain my reasoning and then doctor, could you look at some of my other teeth? My other one's bothering me, and filling came out here, and I have to stop and say, okay, one, I don't do some of that work. Two, if this is like a football team, the dentist is the quarterback and I'm kind of like the wide receiver. I specialize in a very specific task. So we're going to have to get you back to your dentist to get a full plan and look at all of those teeth that, are causing issues. But how could a specialist help a general dentist comprehensively plan? Because it kind of seems like we're stepping out of our zone there. What are your thoughts on, is there anything we can do as a specialist?
Yeah, boy, Grant, you just said something that's very, very true. And when I teach my restorative comprehensive courses, I find, and I'm sure you find this too, that majority of specialists out there, when it comes to implant cases, you're the one treatment planning. It just seems to be the way it happens. And the reason is because what we're talking about, the general dentist for the most part, I hate just using that term because maybe there's other kinds of dentists that do it too, but for the most part, I deal with general dentists and specialists together, is you as a surgeon do it because they don't know how to do it. Right? So that now it's on you. Well, if we think about it from a standpoint of just our skill sets, Grant, when's the last time you prepped a tooth? When's the last time you decided a root canal? When's the last time, you equilibrated a bite and decided this patient needs a full mouth reconstruction and things? And ultimately, what you said is true. We need the general dentist needs to be the quarterback, but just not enough of them are trained to do it. So it falls on you to do it. Right? I was doing a program in Delaware a few years ago. And we were doing my treatment planning. We're going to talk grand rounds in a second. We were doing that. And at the end of the 2 sessions, it's 2 days of treatment planning, the surgeon came up to me and says, I've never learned so much about comprehensive treatment planning than I have in the last 2 days. And I said, awesome. And here's the reason. It's, Grant probably doesn't know any more about ortho than the GP does. Grant probably doesn't know any more about this and that than somebody does. But when we put everybody's head together and help each other, that's where the magic happens. And here's the interesting thing. There's so few courses in dentistry, in the United States at least. I don't know about any place else. There's so few courses out there that teach this skill set. You can go tomorrow. Don't get me started. You can go tomorrow and every general dentist can learn how to do all on floor and take all teeth out. You can do tomorrow and learn how to do Invisalign. But nobody's teaching this, let's look at the big picture. Let's figure out everything this patient needs, from occlusion to ortho to perio to everything. And now let's put it together. So the reason my courses over many years became as successful as they did is this is what we did. The surgeons, I'm going to Pittsburgh in a few weeks, and the surgeons sit down and say, let me help my referrals understand comprehensive planning. Because if they don't, and here's the beauty of it for you is, let's say, and I'll use some names of courses that I think are great courses, but they still don't do it at this level. Let's say you're dependent on, did they go take Dawson? Did they go take Poise? Maybe they did, maybe they didn't. But when you bring it to them, now they're there. And now you know what everybody heard and you're in the room with them. So the specialist can be the person that brings everybody together, the facilitator, and helps them understand comprehensive planning. And that's where these courses started to take off, because once I would come into town, or one of the other speakers would come into town, and we did this a few times for them, the surgeons would see their referrals go up, because all of a sudden these dentists are seeing more dentistry than they ever did before, because we're teaching them not only exam skills, we're teaching them verbal skills and big picture planning, which is something that they've never gotten. And if we bring it to them, now it benefits everybody. So that's part of it. And then what we're going to talk about next, I'm sure, because that's in my mind, the next what leads to is, if we're all in a room together looking at cases, it brings this unity of we're this team. And when you're a team, you plan together. When I do my courses, not only would I want you there, Grant, I'd want an orthodontist there. I would love an endodontist there, because ultimately I want everybody that's within the referral team to understand, well, even though I'm doing it all on X on the upper, let's send them to ortho to get the plane of occlusion fixed on the bottom. Let's not just put it in this destroyed lower arch that they just don't want to do, and they're limited income, so they only want to do the upper. But now you're going to have, in the long run, You're going to have something destroyed because you put it in something that had a very poor occlusion. This is where all these things come in. And the magic of bringing everybody together is, how often are you going to have 30, 40 general dentists, an orthodontist, an oral surgeon, maybe an endodontist in the room and discussing cases? You had the benefit of that when you did what we talk about as grand rounds. You did that. We didn't do that. Right? And all of a sudden, we're just supposed to know this stuff, and it just doesn't work that way. Oh, did I lose your?
Sorry about that. Yeah, could you talk a little bit about kind of grand rounds and how they fit into this conversation, how you make them happen, how it works, all that type of stuff?
Yeah, Grant, I know you know this, but there was a Sir William Osler in 1800s from Johns Hopkins was the first one to do what we would look at now as grand rounds, but it was a lot different back then. The history of it was, he's at Johns Hopkins. He's a physician. He's in a hospital. They'd walk around the hospital looking at patients with certain illnesses, and all their residents would be with them, and they're discussing a case. That's just what it is. The beauty of that is the amount of learning the residents got out of that. It's this magical collaboration, and it became so successful they started doing it in other medical schools, and then it became at this level where with technology and the things like that, now let's just put everybody in a room, a bunch of residents in a room. Let's have some mentors in the room, and let's guide them through the process by giving them maybe some simple cases to look at, but getting more and more complex so that they really understand the process of planning. It's not necessarily, and I tell them this during my courses, I don't want you to remember what I'm saying as far as the treatment plan for Mr. Jones exactly, because of, I don't want them to have to, when they go back to their offices the next week, oh, what did Vic say about this? How am I supposed to? I don't want them to do that. Here's what I want them to do. I want them to teach them to think through the process. What are you looking at? Are you looking at planes of occlusion? Are you looking at the amount of wear? Are you looking at their perio? Are you looking at their bone levels? Heck, are you looking at their joints? Are they have a severe TMJ? And ultimately, these plans become a collaboration of the general dentist with the patient, the oral surgeon, the orthodontist, and we'll go through, in my CERC programs, we end up devoting 2 days of cases. Now, here's what we do. These dentists, from a previous session, I've shown them how to find cases within their practices. We bring these cases to the next session, whether it's just photos and cone beams. It doesn't have to be any more than that. And we'll sit there for 7 hours, and maybe they brought in 20 cases, and we'll go through every case, not just what they need, meaning immediacy, but everything they need. And what happens is, about the first 2-3 hours of session 1 of the grand rounds, I can notice them that they're getting a glaze in their eyes, like this is a lot of information. I call it like scrambled eggs. Their brains are just getting to mush because it's just constant. But then by the afternoon, they get this aha moment. They go, I'm getting it. It's not how much I know about a certain case. It's he looks at this, he looks at this, he looks at this, and then he has a conversation with his surgeon or his orthodontist or his endodontist. I'll give an example. Let's say your Grant's putting an implant in number 3. And we're looking at the case, and I look at number 4 during the session, and number 4 looks like an endo, but it's a little shaky. Doesn't look that great. I may say during the course, well, do you think we need to take it out? Do you think we need an endo evaluation? Let's send it for an endo evaluation. Because the last thing Dr. Stucki wants is for him to put an implant in number 3, and then number 4, 6 months from later, abscesses, and now we lose the implant and we lose number 4. See, it's this, or just like I said, let's look at the planes of occlusion. Let's look at all these kinds of things that, are you planning an all on X on the upper? And Grant, I'd love to hear your opinion about this. You're planning an all on X on the upper, and the lower has advanced perio. Okay. Now, is it okay to leave it like that? Is the bacteria from the perio going to give a problem with end up with peri-implantitis on the top? Do we need to get it cleaned up or not? And surgeons all over the country are a little different. And my thoughts are one way, but what are your thoughts on that? And what do you tell your referrals as far as that's concerned?
Yeah, I mean, certainly it will. So we have to have all the perio under control. All the other arch has to be taken care of first before, doing implants and putting all that work into a whole new arch. And so, yeah, we wouldn't if you had a lower arch that had tons of periodontitis, we wouldn't just go ahead and do the whole upper arch because you're asking for problems, I feel like.
Yeah, and I think, again, I may have mentioned this before. It's still my pet peeve. It's when we start talking about all on cases, all on X cases. I think we're seeing this huge prevalence of all on X cases. I mean, a lot, right?
Yeah.
Everywhere in the country, and it's almost as if I practiced full time for 37 years. I didn't always walk. Every patient that walked in my office wasn't an all on X case. So in my mind, I'm going, where are all of these all on X cases coming from? And I hate to say it, but I'm a firm believer that some of these cases that are out there that have been done, maybe for financial reasons, that's one. But I think there's a bigger reason. I think sometimes the people doing the all on X cases don't know how to treatment plan. So what's the easiest thing to do? Slick everything, right? Slick everything, put 4 implants in, put 6 implants in. And that almost, not that, and don't get me wrong, I'm not saying that that's not it takes a lot of skill to do an all on X case. It certainly does. But it certainly lacks the treatment planning skills of maybe saving the upper 6 and putting implants here and there and fixing the planes of occlusion, all the things that really might, because, even implants are great. But what God gave you is better if they're in good shape, right?
Sure.
So, being somebody that lectures on implants a lot of people think that I'm this, everything should be an implant. Absolutely not. I think we should keep good teeth if we know how to work around them and if it's acceptable to do these cases, and plan a case that's better long term, because we all know as dentists is keeping natural teeth gives you better proprioception, gives you all these kinds of things that as soon as you get to an all on X case, that's gone, right? And ultimately, I think in the long run we're going to see, especially the ones that are done by not as well trained. I'm trying to be nice, not as well trained dentists that are doing all these all on X cases, because of lack of training and lack of skill sets as far as treatment planning. And I think we're going to see some failures in the future, which is going to get the oral surgeons really busy because I think we're going to see things that we don't want to see.
Yeah. And this kind of discussion leads us to the question of the exam. Can you tell us a little bit about how your comprehensive dental exam is set up and how it's be effective, like what that looks like?
Yeah, I mean, I think the biggest thing, and so it literally starts, and this is, again, I talk about this in the course, but it actually starts with the phone call. Okay. And here's what I mean. If my front desk is trained at the level where if somebody calls the office and says, I want to see Dr. Martel for an exam, the first thing my front desk is going to say is, that's great. Let me explain that process to you. Okay. Because what we always want to do is make sure that the patient's expectations and my expectations match. So that may be something like, you're going to be here for a little over an hour. We're going to do, full mouth, and we do full mouth probing. We do oral cancer exam. I do a joints check. I do looking for wear. And I'm probably going to do some scans for some models. I'm probably going to, most likely, if I see some extensive work, I'm going to do some photography. And what am I doing? Basically all I'm doing that day, other than interviewing the patient, which is super important about their needs, is I'm just collecting data. But that data is going to give me the plan that we're going to be able to present at a different visit. And this is just how I do things. Been doing it for years. I never present unless you came in, Grant, you had perfect teeth and no cavities, and then, great. You look good, go get a cleaning and we're good. But most, when you're dealing with kind of patients I dealt with, that wasn't the case because they were pretty beat up. So that happens. And then I'm never going to give those patients their answer that day. I'm going to bring them back for a case presentation. And I'm going to go through a tour of their mouth. These are all the things and this is where the photography came in. I don't know how a dentist treatment plans a fairly large case without photography. I don't get it. I don't see how it works for me because I actually show the patients what I'm talking about, and not with a little intraoral camera. It's with a camera. Okay. And we'll sit in my consult room, or it could be an operatory, and we'll go through everything. And I may say to them, you're going to need some implants here, here, here. We're going to refer you to Dr. Stucki for that. But ultimately, it creates this, I want the patient to leave that day, the first visit and say, I've never had an exam like that, meaning thoroughness of it, right? Because when I present to them the next time, they may have never heard all the things that I'm going to tell them. And that's important because it builds this trust and it builds this relationship where I'm going to say to them, I'm not in a hurry. Even if they ask me, what do you think? Here's what I say all the time. First visit, they're done. They go, what do you think? And I go, and I may know a lot of it, but I go, I have no idea. And the reason I'll say that is I say, well, I need to sit down at my desk, look at your photos, look at your x-rays, and tell you everything I need. And I can't do that in 5 seconds. I need about a half hour of my own time to do that. And ultimately, when you come back next time, we'll have a full discussion on this. And if I need to send you anywhere, we'll send you these places. That's how that works for me. Now, on the other side of that is this. What that helps with the specialist is this. It streamlines the referral, because during that presentation, I will have already said, oh, by the way, you're going to need some implants. I work with Dr. Stucki. Here's what we're going to do here. And we're going to do this in a specific sequence that meets your needs and is the best for your mouth. Okay. Which, for example, Grant, I thought we talked about this once before, a long time ago, is I think it becomes much easier for my specialist if I can call you on the phone and say, hey, Grant, I saw Mrs. Smith. She needs 3 implants, 2 on the upper left, 1 on the upper lower right. We're going to splint those 2. And, you may need a bone graft. I already discussed all this with them. She's all set.
Yeah.
Saves you time. And what it does is it reinforces the treatment plan at a level where the patient knows that you know already. We both are in agreement. And when people agree, you're much more likely to get a yes from the patient because you look like this well-oiled machine or team. So a thorough exam, a good presentation at the end, covering everything. I'll give it one little pearl that for your general dentist, or the surgeons are more than likely to share that with their general dentist. There was this thing I learned years ago called the permission statement. Guys, the gentleman's name is Walter Haley. I want to give him credit, but he passed away many years ago. And what I'll do is I sit down with every patient and I'll say to them during the case presentation, I'll say, Grant, I need your permission of something. And you'll say, what? And I say, I need your permission to tell you everything I see, everything I would do about it. Is that okay? And you say, sure. And then I say, and you have my permission to say yes to some of it, all of it, or none of it. But I just want us to be on the same page as we're going to talk about everything, and that's okay. Who's going to say no to that, really, when you think about it, right? It's
right.
We're going to avoid it. But at minimum, and guess what? Are you going to get some no's? 100% you're going to get some no's. That's okay. Mm-hmm. What you should be concerned about as a general dentist, at least, is you've explained everything. Now it's their choice. Yeah. And ultimately, when you do that enough, and this is where maybe if we fall back to the constraints and barriers, this is where some dentists may not want to do this because it takes time, right? It takes time to do the good exam. It takes time to have a consultation, because I never charged for the second visit, which was the consultation. And they were always about 20 minutes, 30 minutes max. Wasn't a big a deal. But I knew that if I invested the time, and I would literally put them in touch with my specialist. I told you before that I never handed cards. We'd call and set up appointments for them. But ultimately, if I had a plan, I would share that plan with you, Grant, as my surgeon, so that we know where we're going with this patient at any one time. Meaning, Grant's going to do the upper this year. We're going to do the lower left next year. We're going over here. See, what dentists tend to misunderstand is if I give them a full plan, a patient, that everything has to be done at once. No, if you truly understand comprehensive treatment planning, you understand how to phase. So sometimes I tell patients all the time, I'm going to give you this plan. It can be a 1-year plan. It can be a 5-year plan. But I'm going to let you know what you need. And we just go there. When you stick to that all the time, and it's not easy to stick to because you're going to kiss a lot of frogs and get no's. But when you commit to it, the general dentist practice changes, the referral patterns change, the surgeons actually end up being less stressed out of having to treatment plan all the cases themselves. And then, Grant, tell me this has never happened. You've treatment planned the case instead of them. Something goes wrong. The general dentist says, well, you planned it. I mean, why didn't you tell me that? Right. That's an uncomfortable position to be in. It should be this collaborative thing, not, well, Grant knows more than I do, so let's just do that. So.
Yeah, I love this topic. I think it's so great, especially if the GP can involve the specialists when they're making this comprehensive plan. For us as a specialist to know what the plan is, I think, like you're saying, just makes things look better for the patient. Things go smoother. So, so much better to involve the specialist than us just to see a patient on the schedule. Okay, implant at number 3, and then we have really no clue what the comprehensive plan is. We see them, we're looking at number 4. That's kind of looks not so great, and we're backpedaling and asking the patient, so what's going on with number 4? And it just if we knew this plan and we were involved in it at the beginning, I think it would go much better. We'd save time because this happens to me all the time. Like I'll look at a number 4 that's next to where the number 3 I'm doing the implant, and I'm saying before we start, what's happening, and usually they've got it taken care of. Oh yeah, next week I'm going for a root canal and a crown on 4, or that happened, recently. And so okay, that makes sense to me, but that communication there where we're involved and we all know what the plan is would be great.
Yeah, I mean, think about that, Grant. Think about the difference between you finding number 4 out, or by the time they get to you, you may have mentioned it, but then they say to you, oh yeah, Dr. Martel told me that already, so I understand. I mean, it's such a reinforcement thing, where reinforcement makes the patient, number 1, feel more comfortable, feel more confident. And it doesn't put anybody in particular, from a standpoint of treating dentists, doesn't put anybody on this, they're out on a limb by themselves. Because if you say something that Dr. Martel didn't say, is Dr. Martel going to get mad? Or
Right.
is the people going to go, Dr. Martel never told me that, right? So, and what I feel it really does is, if you're and I know we've mentioned this in a different way before, if you're the only surgeon, a specialist in town doing this type of teamwork planning with them, Grant, let me tell you something. Again, same thing we said a few months ago. If you make everything easy for them, eventually they're only going to refer to you. I mean, think about it. There's 6 surgeons in town. You're the only guy comprehensively planning with them. Everybody else is just kind of doing triage and fixing emergencies. They're going to end up getting some emergencies, and you're going to end up getting everything else. But until the surgeons, at this point at least, because I don't think there's anything out there that does what we're talking about, until the surgeons commit to the resources to doing these types of programs and bringing your GPs together and helping them learn this kind of stuff, you're kind of out on the limb going, we're just going to do what we've always done. And this is where, I've done these programs for probably 20 years now. And I always say this, the hardest program to do for the surgeon is the one that is the first time they're doing it, meaning they've seen me, they've heard me, but they've never really committed to doing these treatment planning programs. And they kind of go, how good can it be? Well, we'll see. And then it turns out they're spending 2 days treatment planning. And at the end, they're going, wow, because they've seen it and now they appreciate the value of it, as opposed to me just telling them about it. And they go, because everybody's eventually in some way skeptical. Well, maybe it'll work, maybe it won't. No, it works. You just got to make it happen. And when you make it happen, and I'll tell you this, every year for 20 years, as soon as we do these treatment planning sessions, the production of the specialist goes up. Now, is it going to stay up? No, because you have to keep on motivating your referrals. You know that. Human beings take constant motivation. That's just life, right? We're all that way. But when you commit to it, and people that I know, I've seen practices explode because of it, because you're the guy in town helping them, like I said, grow their practice, like we said last time. And ultimately, making your job easier is by helping them understand treatment planning, so that you're not out on a limb by yourself doing it all alone, and then they're just expecting miracles from you, which is the difficult position to be in.
Yeah, this has been really insightful. I appreciate you describing this process and walking us through comprehensive treatment planning. Just wrapping up, what is the big main summary take-home point that you'd like our listeners to walk away with? Is there like something you could boil it down to?
Yeah, I think that I see this a lot, and we're in this battle right now, and I mean we, the dentistry. We're in this battle where there's this battle for production, meaning I think there's a lot of general dentists doing procedures because they want to be more profitable and learning things. And now, there's this, they're doing more implants, so the surgeon's not doing enough implants. And, you're kind of like, you feel like you're losing because of this relationship. I think what surgeons need to think about is this. If you take the time and you spend the resources educating them you're not going to be worried about those other things as much. And the only way you educate them, and we talked about this a long time ago before, is by helping them grow their practices. And by doing that, teaching them how to treatment plan is everything. Now, don't get me wrong. You still need to teach them procedures and how to do certain things. And that's where the CERT program comes in. But ultimately, you have to invest in them, just like, if Grant, I don't know what kind of practice you have in Denver. There's plenty of surgeons out there that, let's pick the city, Atlanta, and they want to grow their practices. Well, they spend a bunch of money on direct-to-patient marketing and stuff. Right. If they took those same resources and invested it in their general dentist, they probably would grow more. And the reason is, when you have patients from direct-to-patient marketing, it's a one-time hit. Right? But if I train some GPs over the years to send you, you have an annuity for maybe 20, 25 years. So that kind of money is much more well spent as opposed to marketing to the public, because you're building this referral system that's going to pump production into your practice for many, many, many years. So if I had to leave it with anything, educate your referrals. Don't worry about them trying to compete with you, because you're never going to change those kinds of people. That's just who they are. And spend your energy and resources on the people that are good, integritous people that just want to help patients become healthier in the long run.
Yes. Oh, I love that. It's a great message. Well, this has been fantastic. I'm sure our listeners are fired up about this topic. Hopefully they're engaged and want to know more. If some of our listeners have further questions for you or are interested in some of your courses, where would you direct them?
Yeah, they can go to, actually, martelacademy.com is my email address, my website, but best thing to do is just to email me at martelacademy@gmail.com. And if they want to learn more about the educational programs I do, or even if they just have a simple question, I'm more than happy to help. I've been helping people that I haven't seen 10 years. They'll text me questions, recently, and I'm more than happy to do it. I'm a dental nerd. I love doing it, so it's fine with me. So
I'll just say a plug here. You're like one of the most thorough, prompt people I've ever communicated with. So I appreciate how amazing you are at communication.
Yeah, people say that I make this promise during my courses, and I have never broken my promise in 15 years, is I give everybody in the program my cell phone number and my email address. And I always say to them, if you ever have a question about a treatment plan or something, I don't care if I haven't seen you in 6 years, text me. I promise you within 24 hours, you'll get an answer. Maybe the answer is I don't know, but you'll get an answer. And I haven't broken that promise. So that tells you how much of a dental nerd I am, but I enjoy it. So that's fine with me.
Awesome. You're the man, Vic. I appreciate all you do to help us learn new things. And it's been fun.
Take care.
Thank you. Okay, have a good day. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayOralSurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.